everyone. My name is Ann Greiner, President and CEO of the Primary Care Collaborative. We are a nonprofit, multi-stakeholder organization that brings together diverse stakeholders to strengthen and reimagine primary care. This afternoon, we're going to have a very interesting and important discussion about the importance of independent primary care practices. As you may or may not know, the majority of physicians are no longer are in independent practice, and that has been changing over the last number of years, exacerbated during COVID-19. We've got a wonderful set of panelists that are going to help explore the issues related to independent practice. The National Academy of Sciences, Engineering, and Medicine called out independent practice as really important as we move forward to strengthen primary care, although they didn't define independent. And they also suggested that when we think about payment models that can strengthen primary care, that they should be adequate enough to support high quality, independent primary care practice, yet flexible enough to support an emerging array of new payment models, many of which have moved far down the value-based payment model trajectory, if you will. Now, let me introduce our panelists, and I'm introducing them in the order in which they will speak. But before I do that, I'd like to invite you all to the launch of PCC's new campaign focused on rebuilding and reimagining primary care. Well, this launch will occur next Tuesday from 1 to 2 p.m. Eastern Standard. We have a fantastic lineup of speakers, and we'll be laying out a new campaign that is focused on furthering and adapting the recommendations that are in the NASM report that are focused on both payment and new investment in primary care. Now for our panelists. First, I'd like to introduce Alan Dobson because he will lead us off. He is currently the chair of the Board of Managers of Community Care Physicians Network, CCPN, and that's a clinically integrated network of more than 3,600 clinicians in more than 1,000 practices across North Carolina. CCPN is dedicated to providing support to independent primary care practices, allowing them to thrive under value-based payment models. He's founder and past president and chief executive officer of Community Care of North Carolina. They are a member of the PCC, and they provide population management and primary care medical home services to 1.6 million North Carolinians. Dr. Dobson has been very active in the health policy arena. He was a frequent advisor to the National Governors Association and is regularly tapped as a speaker in forums across the country. He's also been a visiting scholar at Brookings. He's a graduate of North Carolina State University in Wake Forest. He's also editor-in-chief for medical economics and an adjunct clinical professor in family medicine at UNC Chapel Hill. Next up will be Sean Kavanaugh, and Sean is Chief Policy Officer and Chief Commercial Officer at Aledade. Prior to coming to Aledade, he was, many of you know him from his CMS days. He was Chief Policy Officer and Chief Commercial Officer, and previously served as Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. He oversaw regulation and payment for Medicare fee-for-service providers, health plans, and the prescription drug. Prior to that, Sean was Deputy Director for Programs and Policy at CMI and worked on testing a lot of new payment and service delivery models, including ACOs and medical homes. Before he came to Washington, he had stints at a number of hospitals in New York City, also worked with state government. He attended University of Pennsylvania and Johns Hopkins. Finally, Elizabeth Mitchell, who is the president and CEO of the Pacific Business Group on Health, the Purchaser Business Group on Health, sorry about that, commonly known as PBGH, that focuses on 3 key strategic areas: advancing primary care, making markets more functional, and purchasing value. And Elizabeth does that by mobilizing jumbo healthcare purchasers. Previously, Elizabeth was Senior Vice President for Healthcare and Community Health Transformation at Blue Shield of California, where she designed Blue Shield's strategy for transforming practice, payment, and community health. Prior to that, she was President and CEO of the Network for Regional Healthcare Improvement and CEO of Maine's Business Coalition, Maine Health Management Coalition. Elizabeth has also been a state representative in the Maine State Legislature. I know Elizabeth from her days on the NQF board. She's also been vice chairperson of PTAC, the Physician-Focused Payment Model Technical Advisory Committee, and has held many other leadership positions. She's has a master's in social policy from the London School of Economics. So as you can see, we've got an incredible lineup to provide their perspectives on the challenges that independent practices are facing in the market, and particularly how we think about independent practices as we move to more value-based payment models. So first question to you, Alan. Let me ask you to reflect on, the organization that you lead and ways that you're supporting independent practices.
Well, thanks, Ann. I think, as you know, Community Care North Carolina has been around for about 25 years, providing support and wraparound support services for primary care doctors caring for Medicaid patients. And as the system started to change, we started to look at who were caring for the Medicaid and uninsured in North Carolina, and kind of shame on us to wait to the end to really do that deep dive. But what was really interesting to see was that, if 1.6 million Medicaid recipients in North Carolina, a third of them didn't have a primary care physician, but those who did have a medical home, over 640,000 patients were seen by independent physicians. Only 344 by large hospitals, 120 by other hospitals, and FQHCs cared for about 100,000 of the Medicaid population. So it was really a kind of a wake-up call, and we decided to create CCPN as a CIN to allow them to work together as North Carolina transition its Medicaid population. But we really learned a lot about the independent practices, particularly in North Carolina, which got us thinking this is a timely subject, because as people are talking about going to risk and other things, these practices are, one, small. Almost 80% of the practices I was talking about and that you mentioned in our CIN are less than 5 clinicians. A third of them are solo, which really doesn't, attract a lot of attention when you're trying to take care of a population. Over half of them are in rural areas, and they're kind of evenly split between family medicine, internal medicine, and peds, with a few OBs and psychiatry thrown in. But when we really took a deeper dive, 55% of those practices are located in health professional shortage areas, and 80% of the rural practices are located in shortage areas. So, you start saying, wow, we really do need to concentrate on these small independent practices, because they still are out there and they're still a backbone of the health system. And without support, they're going to have trouble playing in the new paradigm of payment reform. And I think that the unintended consequences of all the movement is we may lose a valuable part of the healthcare infrastructure.
Thank you so much. And we're going to have a lot of time to talk about that backbone support and the idea of that. Sean.
Folks who aren't familiar with Aledade, you should know We were created explicitly for the purpose of supporting independent primary care. And the reason is, as the health system pivots from fee-for-service to value, the founders of Aledade realized, well, the clinicians who are most aligned with the success of value are those who don't have a stake, financial or otherwise, in unnecessary admissions or readmissions, excessive specialty referrals, frequent ED visits. And those physicians are the independent primary care physicians. The problem, of course, is, as for all the reasons Alan just listed, left to their own devices, independent physicians often aren't able to act on that alignment. They don't have the data systems to know how to manage these patients, to be able to track them through the healthcare system. They don't have the capital to invest. So Aledade was created where we partner with these practices. We don't buy them. We don't try to acquire them or employ the physicians. We try to become their partners and provide them the support and the services to move to value and to thrive. And it's been very successful. And I think people know the national statistics in the Medicare Shared Savings Program. Physician-led models are vastly outperforming health system-based models in generating better care at lower cost. And that's been our experience at Aledade as well. And so we're now in 38 states, including, we work alongside Dr. Dobson's practices in North Carolina, but we're in many other states. And we're helping our practices move to value, not just in the Medicare Shared Savings Program, but across. We're trying to move all their patients into value-based contracts. So we work with Blue Cross plans and national insurers. And we think a vibrant, independent primary care infrastructure is the only way to move forward in this country.
Thank you. And maybe I'll just follow up with one clarifying question to make sure that this gets unpacked for our viewers. When you say that primary care clinicians, docs, NPs, PAs, whoever they may be, are not necessarily aligned with value, those that are non-independent. Can you unpack that for us a little bit more?
Sure. You could go to the CMS website and look at what happens in a successful ACO. What happens in a successful ACO is patients get more primary care. And because of that, they need fewer ED admissions, they need fewer hospitalizations, and they need fewer specialty referrals. It's in the national, it's publicly available. Well, if you're a health system and you employ all of those folks, you have an inpatient hospital, you've got specialists, you've got an ED, and you've got primary care. The math for the health system is very complicated. You're foregoing revenue a lot. But for an independent primary care physician, when they prevent someone from going to the hospital because they got better care, more timely care, that is not lost revenue to them. And that's why they can act on that clinical imperative much more quickly than a health system which has complicated financials can.
Thank you. Elizabeth.
Yeah, thank you. So for those of you who aren't familiar, the Purchaser Business Group on Health is a 501c3 organization of jumbo employers. Think Walmart, Microsoft, Boeing, and public purchasers like CalPERS, Washington Healthcare Authority, and collectively our members spend over $350 billion a year on healthcare for about 30 million Americans. So they are very invested in purchasing the highest value care, high quality care, and they understand that they aren't getting that right now. They are well aware. And I will share with you the results of a survey that we got literally yesterday. We asked our members for the billions and billions of dollars you're spending on healthcare, is your employees' health improving? 5% said yes. And so we asked them if the answer is no, what are some of the key reasons? And the number one reason in their response was lack of investment in primary care and prevention. They understand that investing in advanced primary care that really integrates behavioral health, that is accessible and it is equitable and truly enables population health management is actually a key strategy to improving the value of the care that they're buying and frankly the outcomes for their employees. And just one quick sort of point of proof there is we also run something called the California Quality Collaborative. And like Aledade, we work directly with primary care practices in California. And we ran a federal program with other plans and partners over 4 years. And working directly with even small and rural practices, helping them get the data systems they need, get the team structure that they need. In 4 years, they were able to avoid over $350 million in costs by avoiding over 50,000 hospitalizations, over 60,000 ED visits. And that is really a proof of concept for our employer members that this is a way to get the right care at the right time in the right setting. So our members are very committed to primary care and are honestly working actively to change how primary care is supported in the country.
Thank you so much. But that is really startling statistic that only 5 of them feel that the health of their employee population is getting better. Of course, we have had a pandemic, and I think that's made things even more challenging. But still, we're clearly not on the right path. Now, let's open it up for more of a conversation. Why should we be concerned about this decline in independent practice? You know, why be alarmed that these numbers are going down? And what exactly are we losing? And what's at risk here?
Well, I think you've heard from all of us that the importance. One, if you lose, from our standpoint, if you lose the independent physician, you lose access for Medicaid and access in the most rural, already underserved areas. 2, they outperform everyone else. So if everyone moves to either hospital employment or corporate employment, you know, the question is, are those incentives aligned to continue to provide the best care? So I think there needs to be some interventions to shift that decline and level the playing field, and make independent practice something that's attractive for physicians and other clinicians to be out there providing those services.
I think that's right. I think
just one follow-up. Sorry, Sean, and any of you want to jump in on this? Maybe we need to separate hospital and corporate, and just see what differences there might be with respect to employment between those two. So open that up. Maybe Sean, you want to take that question?
I'll try. But what I was going to do is sort of take what Alan said and run with it a little. And my point is there's 2 sides to this. When you lose independent physicians, first is where did they go? Largely, before we address the corporate side, largely they've been going to health systems, which in theory could be a good thing, right? Better integrated care, more coordinated care. In practice, unfortunately, the literature overwhelmingly shows what it leads to is higher prices and higher costs in total. So there was a theory where that could be a good thing. Unfortunately, hasn't played out. And then the flip side, as Alan said, and we've all, I think, repeated, which is the evidence also shows that in the major value-based programs, both private and public, when the independent physicians remain independent, they perform really, really well. And when that happens, society benefits, the physicians benefit, and more importantly, the patients benefit. On the corporate side, I think it still remains to be seen. I don't think that's been studied as much. And I assume, and by that you mean, you know, for example, I believe Optum is the largest employer of physicians in the country. I don't know that we've been able to study what that means. I still believe in the truly independent practice, but the jury's out on that.
Yeah, I would just say that we're a bit agnostic on sort of the corporate status, but what matters from the employer perspective is that referrals for specialty care are only made on the basis of quality and value. It's not about contracts requiring referrals. That is what happens typically with ownership. Unfortunately, I'm afraid we're about 10 years too late for this conversation, given how many practices have been acquired. but there are still opportunities to address that consolidation, to enable informed referrals. And another point of evidence is we ran a Centers of Excellence network on behalf of jumbo employers for about 8 years. And what we saw was over 50% of referrals were unnecessary for back surgery, et cetera. So if you have advanced primary care where you are able to really know the patient, have shared decision-making, have data on the quality of the referral and the need and the appropriateness of the treatment, you can really make a difference on not only unnecessary procedures, but overall value, so and quality and outcomes and experience. So we think it's just extremely important that that independence is maintained so that we know that the patient's interests are first.
And are any of you aware of any research that exists or any way to know what percentage of these contracts with hospital systems or other entities have these kinds of requirements about referrals that are, you know, admittedly problematic? Do we have any way of knowing?
I haven't seen any systematic, but you know, we work with hundreds, if not thousands, of clinicians, some of whom have come out of hospital employment, and they'll tell you, as a hospital employee, I was held accountable for RVUs. For there were scorecards on how often I referred to specialists within the system. There was not a scorecard on how well I controlled the total cost of care and the patient experience. The things we would all want them to be held accountable for, they didn't feel that's what they were held accountable for.
Yeah, I think there's rarely any, and I think that would be problematic to have contractual requirements within, physician contracts. However, as Sean says, there's report cards of what leakages they might call it to outside the system referrals, and their data systems are all geared to make sure the patients stay within the system. And I think the pressure for seeing the patients and refer them are there. I think in our latest roundtable with residents, the number one concern of graduate family medicine residents is they can't practice to the scope in the job opportunities. They can't practice to the level for which they're trained because the various employment opportunities are mainly outpatient, adult medicine, and refer kind of situations. So I think there needs to be a lot more study done there. Likewise, what happens is when we lose rural hospitals, we lose, when they become part of a system, what happens over the time? Are more services created there, or less services, and what happens to those practices?
Let's take up Alan's comment about comprehensiveness of services provided, because I think that has both quality and cost dimensions, and talk about that a bit more. The PCC's shared principles and the work that we're doing to strengthen primary care, we believe that we need to not be narrowing the scope of services, but actually be expanding it greatly to incorporate things like behavioral health and, connecting patients to community-based services and addressing addiction and many of these other things. But if we're narrowing the scope, that is actually not addressing patients in a holistic manner, exactly where we don't want to be going. So talk a little bit more about what you're seeing in your environments and what you think are some of the implications of all of that.
Well, if I could jump in here, we convened our members over the last year or so to really identify and articulate what they wanted from advanced primary care. And it's everything you just said, community-based connections, addressing social needs, absolutely addressing mental health and substance use. And that really does require sort of a broader scope of services. We want more done within primary care, and then we want, of course, informed referrals. The problem with that is that that is not how they're being paid, as we all know. And so we actually, we run something called the Health Value Index, and 30 of our Jumbo members authorized us to get data from the plans on some of their top priorities, one of them being level of investment in primary care. Unfortunately, it's averages around 7 or 8%, and it's declining. So right when we are saying we want more from primary care, we see the health plans paying less. And when we then take the next step and say, well, this is what we are looking to buy, right? We want these services here. And as our sort of, as the folks operating on our behalf in terms of building these networks and these contracts, we want you to pay for integrated behavioral health and care coordination and all of those things. It's just not happening. So our members are now stepping back and saying, what can we do differently? And many of our members are actually doing direct contracts for primary care. They're building on-site clinics and contracting directly. And almost all of them that I've talked to have said they are getting far better results. They are integrating things like chiropractic and dental and all of the things that really help manage overall health, and they are not only getting lower costs, which is secondary, but they are getting better health outcomes and better really high satisfaction scores. So they know that really building out comprehensive primary care works for their employees.
And I would add, so the follow along to that is that if you have a large enough employer, that makes a lot of sense. But what happens to small employers in small towns? And what happens to small practices in small towns? And, Sean can weigh on this as well. The smaller the practice, it gets harder and harder unless you aggregate them in somehow and create a community system with shared resources for it to really play out. And I think the same thing is for employers, aggregating employers so that they can jointly contract for those services, because it has to be a tipping point where that happens. And I'll put a plug in for the independent practices from an economic standpoint in communities. They are small businesses. They pay taxes. They employ people. They pay property taxes because they are not for profit. They are, individually owned. So and they're the ones who provide local leadership in the community because, that's what they do. And having practiced in a small town for almost 40 years, our practice was the health system along with the EMS service and a small independently owned pharmacy. If you need anything that we didn't provide, you had to get in the car, and it's 25, 30 minutes to the next where other services are. And that's usually okay for most people. They'll do it. But if you're elderly and disadvantaged, that is a real issue. So,
yeah. So I think it's worth considering how we got here, which is, these independent practices, as we keep emphasizing, are often very small. We actually work with some very large ones, but on average, they're small. The average Aledade practice is fewer than 10 physicians. I think, Alan, yours average was even smaller. And so in the fee-for-service world, they go to the health plan and they're getting the worst fee schedule available. They've got zero leverage because they're seen as a cost center in the old fee-for-service paradigm. And so they get squeezed and they squeezed. And if they want to keep the practice, because it might be important to their rural community, what's their incentive? Their incentive is to see more patients. Well, if I got to squeeze a lot of patients into a 8-hour, 9-hour, 10-hour day, who do I want to see? The really sick, complicated patients? Your incentive is to churn the well patients through. Now, they don't always act on that, but that's the incentive. The beauty of the move to value is it turns that on its head. Now, if I'm a practice of any size, if I'm on a value-based contract, my incentive is actually, I want to reach out to the sickest of my patients. And as Alan said, I want to operate at the top of my license. I want to provide comprehensive care. I've got no incentive at the slightest bump in the road to send someone to a specialist. I want to do everything I was trained to do and wrap my arms around those patients. And that's why we've got to find, one, we've got to maintain this independent sector, and we've got to find ways to help them move to value.
Sean, can I just jump in on something? Because I say this all the time. I think employers and these physicians and small practices want exactly the same thing, right? We are completely aligned. We want you to have the resources. We want you to be controlling those referrals. And so what happens? What gets lost in translation when it goes through the health plan or whatever it goes through? Because we are completely aligned there, and we are trying to make those payment changes. We released something that said, we want to pay more for primary care, and the plans come back and say, sorry, we just don't have the systems to pay prospectively or to look at outcomes, and we've got to stick with this fee for service. So I'd love to just get your thoughts on why we're so stuck when we all agree.
I love your phrase lost in translation, because that's exactly what's happening. When we go to all the regional and major insurers and we get value-based contracts, but often it includes a conversation of them saying, but our large employers are self-insured and we can't include them. And we say, why not? And they're like, well, this is not what they want, or that. And we're saying, but I was just on a webcast with Elizabeth Mitchell, who tells me this is exactly what they want. So it is somehow lost in transition or translation, because we are having that disconnect.
Well, and I would say, primary care is such an insignificant part of the cost. So I've had my payer hat on too. And as an employer, it's such a small portion of what you pay in insurance premiums every day. We'll go and create an incentive offline to pay for a gym membership. I would say to you, buying primary care would probably not be much more than a gym membership. Just give it to them, because and in the end, you won't notice any change, and you won't even notice you paid for it. And Sean, I don't know. I could imagine that we could capitate primary care for basic services, and everyone would think they had died and gone to heaven, right? Because the problem with value-based, you got to wait 18 months or more for the stuff to pay, and then it's how do I get those services? How to get off the hamster wheel? So there needs to be a fundamental change where we really pay primary care well and reward them from doing even better.
What I would add to that is, why are we discouraging patients, beneficiaries from using primary care? So we think the evidence is building, particularly in the public programs, that people who see in an ACO, see their primary care doc, get a wellness visit, get their chronic care management, transitional care management, are generating cost savings. So we've been suggesting to CMS, why don't you waive the co-payments for that? Like, why do they need skin in the game for wellness and prevention? Why don't we actively encourage that?
And when you're talking about capitation, you always say, well, if you capitate it, you'll encourage overutilization. And in primary care, who cares, right?
Exactly.
And to the point is that, when do you develop relationships with patients? When do you find the things that you could head off? It's usually in the inconsequential visit, which has nothing to do with, you find stuff when they come in for a cold or whatnot that's missed if they're not seeking that care in an advanced medical home.
Yeah. The way that our members have been thinking about it and articulating it is they want to pay prospectively. They want flexible population-based payments to, not micromanage practice or have that fee-for-service hamster wheel, but pay them appropriately, effectively, and flexibly. And they want a small set of outcome measures to make sure that people are getting healthier using patient-reported outcomes, not just, HEDIS and those, old metrics that really aren't robust. So looking at outcomes, including like depression remission, right? It's not just did someone get screened, but are they getting better? But have that sort of replace the current sort of prior auth and fee-for-service that isn't enabling health. So more payment and accountability for outcomes.
And I think Sean,
a lot of concordance across the three of you. And just to bring it back to the independent practice. So we ideally want to make sure that independent practices can move into these models, these prospective payment models. And yet they're going to need more, as you described it earlier, Alan, quote unquote, backbone support. And there are a number of different ways that backbone support can be defined. Why don't we talk a little bit about what that means in terms of backbone support and the different methods to give people a flavor. Would you like to start, Alan?
Sure, and Sean, you weigh in as well. I mean, it starts with aggregating data and looking at data differently. And it has to be from multiple payers aggregated in where you can give practice meaningful data, useful data in managing their patients. Then it's followed by those things like care management, care coordination, those things that will help you care for your population, and being able to allow them, aggregate them so they can participate in value-based contracting. Because if you're a solo practice, you don't have enough patients from a single provider to be able to even play, because it's not statistically significant, even if you're providing the best care there is. And I would say one additional thing that we're learning is the practices need practice support related to the complexities of just being a business owner and being a business, running a small business, because that's what they are. When we surveyed all our members, guess what their number one concern was? Their health insurance for themselves and their employees. The same thing Elizabeth was talking about. They don't have the option even to buy their own services for themselves and their families. It's in this insurance quagmire. So I think those are the kind of, I guess, the caveats. Sean, you could, throw in if you think of some more buckets that they need. And then the question is, and I don't know that we got the answer to this, what's the most optimal way to scale that down to a single physician? I would almost call it like I know a little bit about restaurants and in my retired life, but it's like you don't have to be a chain restaurant to serve good food, but in a small boutique high-end restaurant, the chef and the owner do a lot of those functions themselves. So it's the functions, not the people. You might have a single nurse doing care management, care coordination in the right payment structure with a solo doc, and they'll knock it out of the park.
Yeah, so I would divide it up into two areas. One is, before you even talk about value, the practice has to be able to exist. So whatever the underlying day-to-day payment, if we're going to have the current construct where value is really a payment coming down the road as opposed to being paid every day, the fee-for-service schedule or the PMPM has to be better than it is today. We work, as I said, with clinicians in all these different markets, and some of the fee schedules we see are just unbelievable, like fractions of the Medicare fee schedule. And to ask that practice to now do more work to move to value is just outrageous. So there's a whole array of things, adequate payment, and then Alan got into and there's small business people helping support them, just running it, and they're all replicating. This isn't a chain restaurant, but it's all these boutique restaurants who are doing the same thing. They're all doing payroll, they're all doing laundry, so how do we scale supporting them but still allowing them to maintain their independence? And then when you shift to the value discussion, you can very much, and I think we've seen it both with public and private payers, you can tailor these to independent practices. You do need to aggregate them, but if you have a collection of independent primary care practices, do you need them to take the same level of downside risk as a large, multi-state health system? Of course not. The downside risk just has to be large enough to motivate them to be engaged and do the work. And in fact, there isn't even a huge body of evidence that downside risk is absolutely necessary. But we like the downside risk because it gives us more of an upside opportunity. But you can dial these things, and it's one size does not need to fit all. A group of primary care physicians can deliver great care without the same level of risk as a big health system. And there's a lot of other features. I love that Elizabeth said a parsimonious set of quality measures. I am guilty of administering a program that did not have a parsimonious set. Like we hit third, and now being on the other side, the notion that someone's accountable for more measures than they can even remember, like they couldn't even rattle them off the top of their head, is kind of crazy, right? If you can't say what the measures are, how are you working day to day to improve them? So I think those are all the things to do, but they're all doable. And as Alan said, the financial side is not a huge investment, but we got to keep these folks alive before we move them to value.
Can we just underscore that? This is all doable. This evidence has been collected over decades. It's not that we don't know what is, best for patients and communities. So I really hope that, in your work, and you also start looking at the barriers to actually acting and implementing, because frankly, we're losing independent practices, all the time because of the market dynamics. Consolidation accelerated dramatically during COVID. And, as Sean said, all the evidence shows that that does not improve quality, it does not improve experience, it just drives up pricing. So what can we collectively do to really reverse this trend is what we should be focused on.
Well, I'd like to go back to what Sean said. I mean, I think we almost have to start by leveling the playing field on basic payment. Even if it's fee for service, then so be it. But the reality is that independent docs get about 30% less for the same work than if you're selling your practice to a hospital. Suddenly the amount of money that you're getting and it's being charged to the system goes up. And if you sell your business, then that building goes off the tax base as well. So we've created the unintended consequences to get exactly what we want. So at some point you have to go and fix the base rate of payment, even in the old archaic fee-for-service world where these guys can stay alive.
So I had that conversation recently with a health plan CEO that can remain unnamed, and that person said to me, "What, you want us to take money from hospitals and specialists?" And the answer was yes. We do want that money to go to primary care, and if it requires reallocation, we think that's appropriate.
I used to call this budget dust.
Mm-hmm.
Right? If you consider you're spending 6% on primary care, Sean, you guys may be better at math. So to give a 25% raise on the 6%, what would that mean in the cost structure upstream? It would just be, you wouldn't even notice it.
This is the rare occasion where I'm going to speak up for my health plan colleagues. Yes, we want them to take it from hospitals and specialists, but the reason they're giving it to them is we as a society have allowed the hospitals to consolidate, and the hospitals have market power. And so that's something we need to address too, which is I don't think health plans are paying a much higher rates to consolidated systems because they want to. It is a market dynamic, and it's a market dynamic that occurred because we as a society allow them to consolidate. And I do think that is a harder problem to solve. The only paths out of that I can think of are both very tough. One is to break up health systems, and I'm not advocating that. And the other is, rate setting, is to limit what they can charge. And I know a number of people are now advocating that. I have a history, and earlier in my career, I was a rate setter in the state of Maryland. And all I'll tell you is it's hard work and people hate it.
It's a real thankless job, right?
Yeah. But once you have a consolidated market, I'm not sure what other policy responses there are. And so the health plans, in many cases, are between a rock and a hard place.
Well, I would say all of this is hard. Yeah, rate setting's hard, value-based contracting and consolidated markets is hard. It's all hard, and we've got to do something. So, Sutter is an example of what you can do about a consolidated system. And we think that the injunctive relief provisions in there may actually, shift the market a bit. I'm not saying everyone can go through 10-year lawsuits, but what about the FTC? Where have they been on this? We think one of the policy issues at the federal level needs to be taking on consolidation in the healthcare system, because it's not giving us the outcomes that we need. So I agree, it's hard, but it's got to be tackled.
And some state leaders are tackling this. The ones that have stepped up to the plate to, look at primary care spend by health plans, carving out ERISA, trying to understand what is being spent, and then putting in place legislation or regulation to increase spend in primary care. That's a requirement that the health plans need to put in place. We saw that first with Rhode Island. But a state answer, lighting fires around the country is only, in a limited number of states. It takes time to grow over time. We also do need, some federal solutions, clearly. I also wanted to just touch on, Alan, your notion of, the support system. And one thing you didn't mention, which is, I think, increasingly how we think about advanced primary care, is behavioral health integration. You talked about, care management and, the likely cultural competent care that these practices are providing, and really attentive to chronic care management. But what about issues like behavioral health integration, and where does that fit into the construct?
Well, I think it's important. Most of us who've trained all of us who've trained in primary care, that's a core portion of our competencies. The need is great. My practice had an entirely embedded mental health division inside all our practice sites, and where you're a solo practice, you have a relationship with someone down the street. I think this goes back to the same reason that we're losing independent practices. Payment for primary care, behavioral health services are a real problem. It's a subject at every one of our board meetings that that pediatricians who have embedded behavioral health clinicians have trouble getting reimbursement from plans, because mental health traditionally has been carved out at almost every plan benefit to a third party. So therefore those payments don't flow across. So it is a daunting task, but it needs to be part of the equation. And I think it can, if you're large enough to support behavioral health clinicians in your practice, great. If not, there needs to be a collaborative relationship with someone down the street that you work together with to provide a better population management kind of approach for your community.
Yeah, I think,
Go ahead, Sean.
Just briefly, one of the things, as Alan says, a lot of it does go back to payment. Mental health professionals feel like they're not paid appropriately by plans, so they're not in network. Therefore, for our practices to work with them in a collaborative, integrated way is hampered by the fact that they're not in the same financial system. And that's one level of complexity. And the other level of complexity is the workforce. Like, are there enough practitioners? Are they in the right communities where the need is greatest? I used to live in New York City. There were plenty in certain neighborhoods. There were absolutely quite a few psychiatrists, but you could travel out to the outer boroughs, and the supply of mental health professionals changed dramatically.
One thing also to put on the table is telehealth, mental health, psychiatry, and other health professionals or behavioral health professionals. And I think a lot of practices are beginning to leverage those kinds of services to meet their patient needs. So that's another one to consider. Now I'm looking at some questions that are coming in, and thank you so much. Please keep sending them. The first question was, what percentage of primary care clinicians, and we only have this number for physicians, are independent, and it is less than 50%. The follow-up question was, folks coming out of primary care residencies don't seem to be choosing independent practice. What can we do to sweeten the pot? And how do we make the case for these new practitioners to think about setting up their own practices?
Partly they're not doing it because they're coming out with debt, and the notion of starting their own struggling small business is pretty daunting. Part of what we hope to do is create a track record of showing them you wouldn't be just starting a small business based on the fee-for-service rates, which are very low, but that you hopefully would start out in value-based contracts with support from Aledade, CCPN, or somebody. And our record is we do greatly increase the money they take home. I don't know that we have a long enough track record that people are shifting careers coming out of residency yet based on that, but we hope to get to that point. And then I think where we need to go is, what if we had a turnkey solution? What if they could walk out and someone provided them with real estate, an EHR, contracts, support staff? It was a turnkey solution, and they paid for that not by taking on more debt, but by generating value going forward and ceding some of that value to whoever fronted that. I think there's a lot of ways to make the independent primary care life better, and I think a lot of people are starting to think about that and how to fill that void.
Yeah, I think there's, talking to residents, I think there's an opportunity there. But again, they're in residency trying to learn. They have no exposure to independent practice. They're the invisible workforce, right? And they do, because of the complexities of health systems and how residencies are set up, having them go rotate with an independent physician in rural areas is somewhat daunting, right? It's a lot of work to go out there to see them. So there's really no avenue out there. If they were to want to, as Sean says, to go into independent practice, it's almost overwhelming. Maybe it's easier just to take a job, and the jobs they see are mainly in health systems and in employed situations. So I think there's work that needs to be done as a national framework. And, as Sean said, maybe there's a series of things. I just belong to this club and this club and this club to be able to get the services I need, because you can lease computers now, you can lease everything. It shouldn't have to be a daunting, overwhelming financial commitment to go provide the care needed for a community.
What if you could get National Health Service Corps loan forgiveness by starting a value-based primary care practice?
All this. What if you are tax incentives? What if you could get tax incentives to be an independent practice in a community of need? I mean, if you just look at the ones who are remaining in North Carolina are independent, and over half of them are in healthcare shortage areas. I mean, that just blows my mind, and it's not a small number. It would be really interesting if we had a snapshot around the rest of the country. I tend to think that North Carolina is totally unique in that regard, but we just don't know where they are.
You're not. Aledade, as I said, we work in 38 states, and 56% of our practices are either in a health professional shortage area or federally designated medically underserved area. And I think that's what you're getting is a healthcare system is divided between large consolidated systems in the urban and suburban areas, and leaving the independents and federally qualified health centers for serving everybody else, which I don't think is a system any of us really want to see.
Right. And that your number meets our number, 56, 55, 56% are in HPSAs. And it's even greater in the rural areas.
Yeah, well, putting this data together to make the case for those who are trying to make strides to address the health inequities that we've seen over the last 2 years, there may not be an appreciation for this conversation about the role of independent practice. So connecting those dots, I think, could be really helpful. We just have a couple of minutes remaining, and I'd like each of you to have one parting shot. If you could wave your magic wand and get one policy that the federal government would put in place to help independent practice, what would it be?
Just one?
We've only got a couple of minutes.
Well,
I'll
go ahead.
I'll jump in. One, I've already said it, like stop the consolidation. There's pending potentially federal legislation, get the FTC involved, but you know, stop the consolidation so that practices can survive. But my actual parting shot would be, we cannot be here 5 years from now still talking about this. We have got to act federally, through the markets, through all these, you know, the leadership of Alan and Sean and their groups. But it's just not enough to keep talking about it because we're losing ground. So I'd love to think about how we act and collectively.
Thank you, Elizabeth.
I would just say, you know, Alan, several of us have made reference to that, you know, hospitals receive higher payments for the same services that independent practices provide. I would take that subsidy away from them, build it into payments to primary care providers.
I would support that.
But only because you're limiting me to one. I got a whole list.
Great. So those two, I'm glad you let me go last. I would say then we really have to have the federal government open up residency slots for primary care. We've seen growth of medical schools, but we've seen not the growth in family medicine, pediatrics, and internal medicine necessary to fill the slot for primary care physicians. And if you're going to have a high functioning team, we got to have more out there. So I would add that to the mix.
Thank you so much. I also want to thank Commonwealth Fund for helping to support this webinar today, and underscore Elizabeth's comment. We're done with talk. And I think if the last 2 years haven't illustrated that we need to move to action, and, you know, fast, I don't know what will. So I look forward to working with each of you as we move PCC's agenda forward. It is an upward climb, but piece by piece and step by step, I think we can move forward. So thanks so much for your time and for all the work that you do.